Welcome, and thank you for joining us for our live Q&A program entitled Clinical Issues in Alzheimer's Disease, Debates and Discussions about Diagnosis, New Therapies, and Healthcare Delivery. We're joined today by Dr. Marwan Sabbagh. Dr. Sabbagh will be answering your questions on the treatment of patients with Alzheimer's disease.
Thank you, Matt. And I'm Marwan Sabbagh, professor of neurology at the Barrow Neurological Institute in Phoenix, Arizona. Spend all of my day job as a dementia neurologist, seeing patients 60, 70% of the time and doing research 30, 40% of the time. I have several questions that have already come in through the chat, and I'll get going on them while we wait for more to come in. The first question in the chat that came was, and this is from the program that was during our AIC conversation on July 31st. Do you recommend the AD8 over the mini-cog as a tool initially in the clinic? So the AD8 is an Alzheimer's disease 8 question, informant-based questionnaire that the informant of the patient would answer, capturing incident cognitive decline. There are 3 of these kinds of informant-based questionnaires. AD8 is the most common and well recognized, but the other 2 are Alzheimer questionnaire, AQ, and the third one is the IQ code. These are informant-based, so these would be on the part of the HPI, history of present illness aspect, and not necessarily as a cognitive bedside screening, because the reason I'm saying that is the second half of this question is mini-cog. Mini-cog is very brief, would be similar in style to a MoCA or mini mental state exam. So those would be cognitive assessments. So AD8 is an informant-based questionnaire like AQ, like IQ code, whereas a cognitive assessment would be a brief cognitive assessment, mini-cog, MoCA, mini mental. So I would do both depending on what I'd like to do. Myself, in my practice, I would do an AQ, Alzheimer questionnaire, and then I would do a MoCA as part of the cognitive assessment. So I would not do either one, but both, because they serve different purposes. The next question that came in through the chat is, what will happen when insurance companies know the results of genetic testing, particularly in patients under 60? It's a very good question, a very controversial question, and a difficult question. The fact is that APOE genotyping is not routinely done in clinical practice and has not been recommended routinely in clinical practice until this year, 2022, and we'll talk about that for a second. I will tell you that we would only APOE genotype patients in patients who are having symptoms. So if you do not have any measure of clinical symptoms of cognitive decline, we would not recommend patients getting APOE genotyping. The specific thing, and this is important, is that Congress passed a law in 2008 called the GENE Act, which says you cannot lose your ability to get healthcare insurance on the basis of your genetics, but you can lose your ability to get long-term care insurance. So I only test APOE genotyping in patients who are clinically presenting to my clinic with symptoms of cognitive decline. I would not do it in patients who are asymptomatic, who would just walk in and say, I want to be tested. I would not do that. So the reason I say this to you is we would not routinely do APOE genotyping in clinical practice. That is about to change. I will say to you, one of the things we talked about in our clinical, in the appropriate use recommendations around the new monoclonal antibodies is the idea of doing APOE genotyping, not for diagnostic purposes, but for risk stratification screening purposes. So that's how I don't think the insurance backlash is going to be as complex once we start doing it for risk stratification. The next question that has been asked in the chat is, do you send patients to a genetic counselor for prior to genetic testing? And the answer is, I do not. What I do in my practice is I say to my patients, I'm going to do this, and I explain why I'm going to do the APOE genotyping. Remember, it's a cardiac risk test as much more than it is a neurological test. So if you're an APOE4 carrier, that's a proxy test also for heart disease and hyperlipidemia as much as it is for Alzheimer's. So I code this as a cardiac risk encounter, meaning hypertension, hyperlipidemia, diabetes, heart disease, et cetera. So I do not send patients to genetic counseling, but I do disclose I will do that. I never do it routinely. I tell them right up front, this is what I'm doing and why, but I don't routinely do that. The next question about ApoE is, how does genetic testing affect a patient's ability to get long-term care insurance? And to my previous comment, yes, that is the case. It can lose your ability, it can affect your ability to get long-term care insurance, but that's why we would not recommend testing people who are clinically asymptomatic. It's important to understand that I'm testing patients who are symptomatic, meaning they have mild cognitive impairment or mild dementia. And so the reason I say this to you is that those patients wouldn't qualify for long-term care insurance anyways. So on a routine matter, in asymptomatic people, we would not recommend testing. I'm only testing people with ApoE for risk stratification or proxy diagnostic, only in patients who are symptomatic walking in the door. The next question, how impactful is tau PET effects on AD trial results compared to plasma CSF tau changes? Ooh, that's a good one. That's a very complex one. So tau PET, to this audience, you need to understand, was approved in 2020 or 21. The compound commercially is called Tauvid. The chemical name is fluorotaucipir, and it is a tau-specific ligand available, not for research. It is available in clinical practice. However, as you know, it has not been reimbursed by Medicare. Tauvid is very, very expensive, to the tune of $9,000 per test. So I will say to you, is not routinely used in clinical practice. The reason this is important is one of the studies that was done, this is the donanemab study, the Trailblazer study, used tau burden on tau PET as a measure, as a screening criteria for enrollment in the clinical trials. That was the first time it was ever done, meaning that if you had too much tau or not enough tau, you were not eligible. The question that is being openly asked in the research space is, will that become a new practice? Will we select patients on the basis of their tau burden on tau PET or on plasma results or on CSF? The answer is, it is possible. It is not routinely done yet, but it is possible. And I think you'll see more people being excluded on the basis of their tau signal in clinical trials. But I don't know if that's going to make its way into clinical practice. I do want to say that. Tau PET being expensive, you will see there has been a big push to incorporate CSF testing and eventually plasma testing. So to let you know now, CSF testing is becoming much more common. You know, for all the lumps and bumps we saw with the aducanumab rollout, I will tell you that I am now doing biomarker confirmation on my patients way more than I did a year or 2 years ago. So patients coming in the door with a mild cognitive impairment due to Alzheimer's disease, you know, we used to do a clinical phenotype, MRI, B12, TSH, neuropsych, and we would stop there. But now I'm saying that we're now moving toward biomarker confirmation. So CSF testing or PET, amyloid PET testing. We're doing CSF testing in our clinic about 1 to 2 a week, and it has become pretty common. So I see CSF testing becoming more routine than it has been in the past. I will tell you that plasma testing, p-tau 181, 217, or 231, are being proposed. The research field is abuzz with these kind of plasma tau tests. We could expect to see them in the clinic within a year from now. So I think that the TBD to be decided about whether plasma testing for p-tau will become clinical practice, but that could happen in the fairly near future. The next question is, are statistically significant CDR sum of the boxes clinically meaningful? Ooh, what a juicy question. So the CDR is the Clinical Dementia Rating Scale. The CDR is the clinical trial instrument we use in research. We don't use it in clinical practice. And the reason we don't routinely use it in clinical practice is because CDR takes a while to administer, right? So if you have a 20-minute, 30-minute visit, you don't have the time to do a full CDR, which is a structured 9-page instrument that you do, a trained rater would talk to the informant first, 6 pages of that structured interview, and then they do a assessment of the patient, again a structured interview, and then there's a grid with 6 domains, and then you have a 0, 0.5, 1, 2, or 3, meaning normal, mild cognitive impairment, mild, moderate, and severe dementia for each of these 6 domains, and then you come up with the sum of the boxes. You add all the boxes on each of from the row. So the reason I say this is the CDR sum of the boxes will not become a part of clinical practice, has never become part of clinical practice. But the clinical meaningful question is a critical one. This is the question that has been plaguing the field and plaguing the FDA in a regulatory way. So do you understand that I do this for a living? So I'm sorry if I'm speaking jargon, please stop me, and I apologize. The reason I say this to you is in previous monoclonal studies, they used to use a clinical a neuropsych instrument called the ADAS-Cog, the Alzheimer's Disease Assessment Scale, cognitive scale. And the ADAS-Cog was a quantitative instrument. And what the FDA used to openly ask investigators is, how many points do you need difference on an ADAS-Cog to be clinically meaningful? I mean, clinical meaningfulness is, can we translate a clinical research measure into a clinically demonstrable effect in daily life? The reason this is super important is that what has happened in the current clinical trials, whether you're looking at aducanumab, donanemab, gantenerumab, and lecanemab, these are the 4 monoclonals that are kind of working their way through the system. Aducanumab already approved. The field and the FDA has determined that CDR is a better way to determine clinical meaningfulness than the previous use of the ADAS-Cog. So we don't use ADAS-Cog to divine or determine or interpret clinical meaningfulness. We use the ADAS-Cog. And the answer to the question, are statistically significant CDR sum of the boxes clinically meaningful? The answer is yes. So a half a point should be enough to determine, could be a way of determining clinical meaningfulness. So the answer is that's what we are seeing now is the CDR as the approvable test to get a drug approved in front of the FDA. So remember, last year you had aducanumab approved. For all the lumps and bumps, Medicare not reimbursing it, but it is an approved drug. It is actually, most people not realize it's the only drug approved for mild cognitive impairment, and it is the first disease-modifying therapy. So the reason it's important is that we now have a benchmark, a kind of a watermark to determine what the drugs, other drugs like lecanemab, donanemab, gantenerumab might have to go through. The next question is about CMS's National Coverage Determination, or NCD, for aducanumab. Will that change when lecanemab, donanemab, or other monoclonal antibody DMTs obtain positive data? Ooh, what a good question, and a very controversial question. That's a very technical question, so let me tell you, I'm sorry to give you the long version of the answer to that question because it's such a complicated question. FDA and CMS use different criteria for approvability. So if FDA is looking at scientific validity of the clinical trial evidence to determine whether the drug should be approved to treat patients in the United States. FDA has historically used clinical trial outcome measures, meaning a CDR. If the delta between the treatment and placebo is enough, then they would say there's evidence of clinical efficacy, and they would give an approval. What they did last year is something unprecedented in the Alzheimer's space, but is not unprecedented in medicine. They said last year that if you removed amyloid, so if you actually look at lecanemab, aducanumab, gantenerumab, and donanemab, those drugs remove amyloid, and they remove them all very, very well. So the FDA last year used a biomarker endpoint saying, that the clinical outcome is not clearly determined, but the biomarker outcome of removal of target pathology is very clearly demonstrated, and that's what aducanumab got their approval on. Okay, so that's the regulatory pathway, and the answer to the question is: do I think the other drugs, gantenerumab, donanemab, and lecanemab, could use the same regulatory pathway, meaning biomarker endpoint first, clinical efficacy to be determined? I say the answer is yes. I think that it is possible that other companies will use the same regulatory pathway. The reason it's controversial is that it's very controversial in Alzheimer's. Apparently, this is the standard way that cancer drugs get approved. If you have a cancer drug and it shrinks the tumor or reduces the tumor marker, that's enough for a cancer drug to be approved. So cancer world uses this regulatory pathway all the time. We just never seen it in the Alzheimer world. It doesn't mean it's not an established regulatory pathway. It's just been new to us. So that's number one. So that's the FDA pathway. I'm saying to you is that there's a new regulatory precedent, and I think that it is possible that the other three monoclonals will use the same regulatory pathway. But the other thing is the second pathway is the CMS pathway, the Medicare pathway, which is, and NCD stands for National Coverage Determination. It turns out, of course, that CMS, even though they accept the efficacy endpoints of the FDA, they do not have to, they are not obligated to pay for a drug once it's approved. They're under no obligation. So the NCD, National Coverage Determination, they will make their determination on the basis of whether they think they should be paying for drugs like aducanumab, donanemab, lecanemab, and gantenerumab. And so the question is will this regulatory pathway that uses a biomarker affect the national coverage determination? And if you believe the aducanumab data, the answer is yes, possibly yes, that it will influence it. So my point is that they're separate pathways, but they are important because if they're using an expedited pathway, meaning the biomarker endpoint, that may affect national coverage determination, and that will affect whether the drugs are available and prescribable and reimbursed. The people on this audience are practitioners, probably like I am, a neurologist. This becomes very relevant, right? I'd love to write a drug and have it reimbursed, but if it's not reimbursed, the chances of patients paying out of pocket, it goes down considerably. It's only allowed for the few people who can afford it. So this is a very important question and still very not clearly decided. The next question is aducanumab being prescribed to patients who were ApoE4 carriers? Good question, and I would refer you to the two appropriate use recommendation papers, Cummings et al. 2021, Cummings et al. 2022. I was very privileged to be on the 2022 paper, and this is important. The answer is we would say that we would use ApoE genotyping as risk stratification because there is an increased risk of ARIA on the basis of your ApoE4. And if you're a homozygote, meaning two copies of ARIA, the high risk of having ARIA goes up considerably. So I would say to you that I would do ApoE genotyping for risk stratification and might have a little bit of caution or thoughtfulness before I'd give a patient, homozygote patient, a drug like aducanumab. That said, I feel pretty comfortable giving it to a heterozygote. So that is the answer to that question is it is being prescribed, but I would select patients on the basis of their ApoE genotyping. The next question is, where can I find preclinical trials for ApoE4 carriers? That's an excellent question. I would go to clinicaltrials.gov. I would also look up ALZ Forum. It's a website in the trade. They may have them by genotype. The next question, which is a curious question, and I've seen this kind of percolating, since amyloid beta is antimicrobial, is there a concern that treatment to prevent formation of oligomers could increase risk of infection? So some labs have published data suggesting that there's natural antimicrobial properties to amyloid, and that it doesn't make sense to remove amyloid since it may have biological relevance. But there is a host of data suggesting that amyloid is a driver of pathology. And so the question instead of that is infection a trigger of downstream amyloid pathology or Alzheimer pathology? The question so far is, I will tell you that removing amyloid, whether you're looking at monomeric, oligomeric, protofibrillar, or plaque, has not been shown to increase risk of infection. The next question is, which assays do you use to obtain blood A beta 42 biomarkers? So this is a question that comes from a very, very well-read person. And I will say to you, this has become an area of great research interest. So the reason this is important is that there is now one blood test approved and CLIA certified in the United States. This is the C2N diagnostic out of St. Louis Precivity test. And that is using a plasma A beta 42 to 40 ratio. They already have CLIA certification and they can run the test commercially in 49 states. And that test is now available. It's not a research test, it is now available. The reason that's important is that they are using mass spectrometry as the way to determine amyloid 42 to 40 ratio. I've heard experts talk about the fact that mass spec is a good assay, solid assay, but the question is can it be scaled to be useful at a large level, at a high amount? And the answer is that is to be determined by the experts. The second one that's getting a lot of attention is an assay called a Quanterix Simoa singular molecule assay. The Simoa is seeking regulatory approval, and they have not been commercially available. There are other companies and other technologies that are being developed, including the SQUID IMR technology and others. So the point is that right now the assay that is commercially available is mass spec, but there could be others approved in the near future. The next question is, what should managed care know about anti-amyloid monoclonal antibodies? Well, I can tell you that last year, in July of 2021, after aducanumab had been approved, there was an advisory panel that the FDA and CMS convened called the Margolis panel held by Duke. All the major insurance companies, Medicare, were there. In fact, I was in the room, had the privilege of participating in that. And I can tell you that they have teams of people kind of toiling over the P&T implications, especially if you have managed Medicare. So the answer is they already have rendered an opinion. Their initial impression was not excitement about the use of the monoclonals, but we'll see. We'll see, make that determination. The last question is, how do you think availability of biomarkers will change practice over the next several years? That's a great question to end on. I will tell you that I believe that plasma testing will become part of routine practice within a year or two. We see already the A beta 42 to 40 ratio has been approved. There is now a high probability that p-tau 181 or 217 will be approved within a year. And so you'll see that patients walk in the door, and while you're doing a B12 TSH and MRI, you'll be drawing a assay, including an A beta 42 to 40 ratio or a p-tau 181 or a p-tau 217. And that will be the way we're screening patients. So we're going to be screening patients not on clinical diagnosis in the future, but on their plasma biomarkers. And that could really drive practice. So I think that's a watershed moment that could really, really drive practice.